Right, good afternoon, everyone, and thank you for joining us for our first Falls Awareness Week webinar hosted by the Falls Prevention Network and supported by Medline. Just to let you know, this session is being recorded. If you have colleagues that are not able to join, they'll be able to pick up the recording afterwards, either from the invitation email or we will put it on the Medline website next week or the week after, once all the webinars are completed. Obviously, we've got you all on mute throughout the session, so please put your questions into the Q&A panel. You'll see that at the top of your screen, hopefully. So what I'm going to do, and obviously we'll come to those at the end. So what I'm going to do now is just hand over to Julie Windsor from NHS England to introduce our today's speaker. Okay, I'll just put you on the screen, Julie. There we go.
Hello, hi, happy Falls Awareness Week, everybody. My name's Judy Windsor. I work for the National Patient Safety Team, and thank you very much for joining for the first of several sessions that will be running over the next couple of weeks, which I hope will be of interest. If you're wondering how we selected all the topics, those of you that are members of the network on Futures will know that the topics do tend to come up with some regularity. So essentially what we did was look to see which were the most common Q&As being asked on the network. So that's why we've tried to align some of the sessions over the next fortnight with those main topics. So today, to start off with, then we're just going to introduce an ex-colleague of mine, in fact, Paul Lee, who is a consultant clinical scientist and head of equipment management services in Swansea. And he's been instrumental in developing some e-learning coursework, which came out of the National Patient Safety Alert that some of you may recall, that was published in August 23, along with the MHRA updated bed rail guidance. And as a result of that work, it became apparent that there were still difficulties with people having adequate knowledge and skills, really, with provision of these equipment. So long story short, Paul was asked to develop some e-learning, and he's here today to share it with you. So without any further ado, I'll hand over to Paul. Thank you.
Okay, thank you very much indeed. I don't know if the term ex-colleague is correct, Julie. I like to think we're still a colleague, actually. So Julie and I met when I worked for the Department of Health NHS Patient Safety Team back in 2017. And I was, I suppose, introduced to the sterling work that goes on behind the scene by the Patient Safety Team. They look at incidents and errors and trends and try to make recommendations to improve things and send it out to colleagues in the NHS, private sector, etc., to see if we can improve patient safety. And that's what my talk about today is about: patient safety, in particular, the work around beds, bed rails, transfer trolleys, and other such similar devices. So I've got a PowerPoint presentation that I put together for you. There's a couple of hyperlinks in there. Also, a couple of short videos. Hopefully they'll play for you and you'll be able to listen to the audio as well. They're also embedded into the e-learning course. So I'll take you through the slides and say welcome to a very sunny Swansea. It's rained for 3 days here, but at least the sun is out. I've been introduced as a consultant clinical scientist. That's my current job title, but I'm also chair of an organisation called NAMDET, which is the National Association of Medical Device Educators and Trainers. That's been going since about 2011. And it's a collection of around 1,700 educators within healthcare around the UK. And we've been instrumental in putting together this training package around this very important area about beds and bed rails. So hopefully I'm on to my first slide, which takes us back almost 20 years to 2007, when the NPSA, the National Patient Safety Agency, as they were then, issued a fabulous report all around the risk around bed rails. Now, interestingly, back then, the research showed that very small numbers of beds actually had bed rails in use, figures lower than 10%, in the region of 8%. Just a few years later, 5 years later, acute hospitals were using over 30%. And by 2004, just one hospital alone, almost 30% of adults had a bed rail in place. And you can see the figures then continue to grow up to 35%. So it obviously started back in 1996 with bed rails, where it was very limited use, assigned on risk, patient risk only, and it's grown and grown and grown and grown, and pretty much every bed you buy today will have a bed rail on it. Now, this report in 2007 looked at all the evidence, but what it identified, interestingly, was about outmoded designs, that's the beds and the way that the beds were used, incorrect assembly, because the bed rails were removable back then. You could take them out and move them and put them back in the wrong place. But rather worryingly, that the introduction of bed rails actually showed an increase in falls, meaning that you can't just apply bed rails just because you think you can. They can introduce risks when you bring them in. So it's important to highlight that. And the paper that followed, Francis Healy's paper that supported that document, had some key messages within that one back in 2008, reinforcing the adoption of bed rails or the use of bed rails on a case-by-case basis, meaning each particular case needs to be risk assessed and the case for bed rails needed to be applied. Obviously, the second bullet point there highlighting the fact that people need to be trained. You'd like to think that was obvious, but I still work in the medical device profession, and lots of equipment arrives on the ward. If you were lucky to be there when the rep turned up, you'd get some pastries, maybe a pen and a bit of training, and that's as far as it went, and that still happens today. There was lots of outdated equipment that should have been removed, so equipment needs to be maintained and serviced and taken away when it's no longer needed. And of course, the right bed rail needs to be fitted to the right mattress. And if you put a mattress onto a bed, then you change the mode of the bed. So there's lots and lots of issues that were raised back in 2007 and 2008. This is a worldwide issue because back in 2010, the American Nursing Journal also had a really good article on bed safeties and bed rails. Their research suggested it was back in 1949, so literally just a year after the NHS was first invented in the UK. The first recorded split-side bed rails was manufactured, and it was designed to assist preventing falls and assisting transfer from beds. Notice it's preventing falls, not for keeping patients locked into a bed, but for preventing falls. And the use of bed rails was based on a consensus rather than scientific evidence, although we'd all like to think, of course, it's obvious that you need a bed rail, but there is some science required behind it. Now, in America, by the 50s, 63% of falls would associate with elevated bed rails. So when you introduce a bed rail, you introduce an additional height and a potential of increased falls. And it was concluded in the 80s, prior to Fran Healy's paper, that bed rails are causing more harm than good. So a significant body of evidence exists to indicate that patients fall from beds despite the use of bed rails. And it's because people record incidents and they use the MHRA yellow card system and they report through Datex and STICE and other reported software programs that the patient safety team at NHS Improvement and others, we have our own version in Wales, are able to learn lessons. So my shout out today to you is, if there are issues or you have problems, please report them, because it's from reports that we can actually generate more evidence and we can make a case for change. Let's go back 6 months. So this is a paper published on Open Research, still complaining about a lack of data around bed rails, and that the use of bed rails may be related to opinions rather than inquiry. However, that when prescribed, there is a responsibility and inquisitive inquiry, meaning people are making the decisions for the right reason, we believe. However, the patient safety alert that came out in 2023, the document shown on the left there, from the MHRA, and it's not the first one, it's not the first one that they've had, reinforced the problems around beds, bed grab handles, bed rails and grab handles, and something I never come across before in my professional career, a lateral turning device. And each of these were grouped together into this alert because there were continued reports of death from risk of entrapment and falls. There are international standards, BS standards, 6061 Part 2 as they call them. So there's one for beds for adults and there's a specific one for medical beds for children, for which the manufacturers are expected to design and build beds that they put onto the market and sell on the European and the UK market. Now, the MHRA have also said that if you've got a bed that doesn't comply to the new medical standards for children, you don't have to scrap it. Obviously, you don't have to scrap it and chuck it out just because new standards have come out, but you need to consider where there may be gaps, and I use that word fortuitously, in the standards versus the beds that you've got, and do some sort of risk assessment about a replacement strategy. The MHRA shared a very, very useful document on their website around the guidance for managing beds and bed rail safety to support the alert. That came out just last year, 2023 actually, with the alert. And the MDSO network, which is the Medical Device Safety Officer network in the UK, they produced an FAQ, a frequently asked questions document to support the alert. And that document is freely available on the NAMDET website. You can get that from the front page for free. And that's been updated just last year. It asks lots of questions from colleagues across the UK as to what does it mean for me? Do we really mean this about bed rails? What if I've got beds that don't comply to standards, etc.? And there's lots of free information advice out there around it. So the background to the alert then. So the alert continues to raise the risks around deaths and serious injuries for beds and related equipment. That's the bed grab handles and transfer trolleys and such the like. It applies to all users of these devices, not just NHS, but care home settings, private, industry, and even those that use them in research in academia as well. Anybody that uses these sorts of products. And it identifies what was picked up in the documents from over 20 years ago about proper risk assessments, maintenance and service and training, and of course the exacting standards to ensure safe bed usage and prevent injuries to patients as well. So here's the document, and the key strapline from this document, if you like, is that over a 5-year period from the beginning of January to the end of December 2022, the MHRA received the following number of reports: 18 reports of death, and that's to do with the beds, rails, trolleys, bariatric beds and grab handles and turning devices, with an additional 54 reports of serious injuries, all of those around entrapment or falls. The vast majority in a community-based area. Nevertheless, major number of reports. And this is just the things that are reported. And these are the ones that cause serious injury and harm. Many, many, many more injuries or potential near misses are reported as well through the DATEX systems as well. So the MHRA posted out and challenged NHS. It's worth saying that the MHRA, by the way, and the National Patient Safety Alert, although issued and was targeted at NHS England, it's adopted by all home nations as well. And Wales took that document. It took a little while to translate it because we have a Welsh version as well. And those 7 actions have all been highlighted and they need to be addressed. And we have to report that back to Welsh Government and the like. And these are the key themes. The key themes were effective maintenance and asset management, service, repair, contract, maintenance, a theme picked up in the very early days. Effective training. Now that's a big issue because training records are usually generally very poor, if any training at all. And staff may have had training once in their lifetime and no opportunity to revisit. There was also one word that was pushed into the alert around atypical anatomy, because that was a theme that was picked up, in that you may have patients of varying shapes and sizes, and you may put a very small adult into a pediatric bed, or you may put an inappropriate sized child into an adult bed. And that needs focus as well. And that's right throughout this risk assessment document. And of course, the single most important thing around this whole process is around risk assessments, and then, not to be forgotten, and this is where organizations can fall foul, updated risk assessments if the patient's condition or situation changes. And by situation, it could mean the patient's physical condition changes or the environment changes because you've moved the bed from one particular room to another room, and there's a whole lot of things that can be around the bed that can cause entrapment issues as well. So it's a key focus on the alert is A, get the risk assessments done, and keep those risk assessments updated. So myself and colleagues, Julie included, and lots of people from across the UK got together and started trying to address the second bullet point there, which was how can we put some training together? So we approached colleagues in the UK and we managed to get hold of a very short introduction course from our colleagues in Guy's and St Thomas. And we took their introduction course around beds and we grew it organically. We grew it. So we had the MHRA, NHS Patient Safety Team, colleagues from this network were contributed towards it as well, clinical educators, trainers, the manufacturers, 2 industry partners, and we put together a training course, an interactive e-learning course with knowledge checks and components. And I'm very pleased to say the course was launched in June this year, so it's been out for just for a couple of months. This is what the course looks like. That's the welcome introduction slide. And as I've said, it's a multimodal course that's put together by lots of different key organizations across many boundaries to address the risks across all the things that were actually listed in the alert. Now, the course itself has got 5 main objectives, and hopefully the objectives are that you will know about the safety standards that are related to the beds and grab handles, and that's both for the adult and pediatric or the children's beds as well. Really importantly, that you would learn and know what the bed rails are for and what they're not for, and that's definitely reinforced throughout the training program as well, and that goes both hospital and community settings. Identify safety concerns and areas of risk with all those products, in particular beds and grab handles, that have been picked up by the alert and the safety investigations. Really importantly, number 4, to know where to get resources from, not just a free e-learning course, but posters and campaigns and FAQs and documents as well. And also know how to report these errors both in your local area of work and nationally. And it's from reporting that's identified this risk that's led to the patient safety alert, I think, that has led to this training course. And without that closed loop system, we'd never have what we've got today. So the course, it's a 30-minute bite-sized learning. We wanted to keep it no more than 30 minutes. It's designed in interactive software called Articulate. We use Rise 360. It's designed to be used on mobile phones, tablets, computers, desktops. You can use your finger to scroll through the modules. There's 9 modules, just a couple of minutes each. There's a couple of little videos embedded into those as well. And you get a little knowledge test at the end of each module. As I've said, they're interactive, and I'll just do a screen grab in a second to show you what it looks like. The videos are built into the training. So there's a 2-minute and a 6-minute video. You have to watch them. You can slow them down if you wish. You can replay them a number of times, but you can't skip the videos. You have to watch them as well. And there is an end of course quiz where it's a number of questions selected from a random pool of questions, which you've already had a chance to see during the e-learning anyway, with an 80% pass rate. It's live and being used as we speak in ESR on the electronic staff record in Wales. My colleagues in Wales are actually about to unlock it for the rest of the UK as we speak, if they haven't done it already. So it should be available for all the other home nations. It's also available through the Learning at Wales website, which is free to access for people who are not NHS, so that's our private sector, care homes, etc. You can actually play it through your learning management systems, and I forgot to mention, if I haven't already, it's free. So please don't think you've got to pay for this. This training course is completely free for anybody that wants to use it. And if you can't access it through the Learning at Wales, or you can't get it through ESR, we'll make sure somehow we try and get it to you. The most important thing, the key messages are emboldened, as you see, in big block letters with bolded text. And the reason we use the bolded text is because that's potentially going to be one of the summary questions at the end of section 1. So you may be asked, what's the purpose of a bed rail? And the purpose is clearly indicated to you in the screen. There's also pictures, pictorials on the right-hand side to reinforce the messages with hyperlinks to standards as well. So when you get through some of the sections, there's interactive quizzes, there's electronic pictures, there's hotspots, and there's basic Q&A questions. So I've downloaded a little short video here to show you what an activity looks like in one of the modules. Bearing in mind the modules are quite short. So this one is a 7-card knowledge check. You can revisit it as many times as you like within the e-learning. You click and drag the cards from the top to the correct box. If you get the answer right, you get a tick. If you get the answer wrong, it just moves the card. So let's have a look at what it looks like. And this first question in one of the modules says, what do you think is the correct use for a bed rail? And you'll see on the bottom left is what they are for and what they're not intended for. So this is me using the e-learning course yesterday. So it's for limiting the freedom of people. It's not for use in the home, not for use in a home setting. It's not, or they are not only for used at night. They are used in acute community. They are used day or night. They are for reducing the risk of occupants falling. Are they for restraining an agitated patient? No, they're not. They definitely are not. That is reinforced in the words and reinforced in the knowledge check as well. And that question does come up at the end of the assessment as well. Now, through working with Julie and colleagues as well, we try to identify the sort of the main protagonists, that all the different types of beds and bed rails that are used. And this is reinforced in one of the modules as well. You'll see on the left-hand side the highlight blocks with key messages. And on the right-hand side is an interactive session. You've got to go through every single one of these little blocks to show you what the beds and bed rails are for. So the first block is about full-length integrated bed rails with some text. Once you've read that one, you move to the second block that introduces 3/4 length beds with bed rails. And there's some text around that as well. Mesh side rails are also mentioned with some pictures and some key important safety messages. And side infills. Notice there's no pictures of pillows there. The orange arrow indicates there's a couple of more tabs to go through. Bed levers, the main issue of concern within the alerts, and as I said earlier on in my presentation, something I'd never heard of before is a lateral turning device, and the MHRA tell me they've actually received instances about patients being trapped in these as well. So that covers all the products, and it's only once you've clicked on all those products will the software actually allow you to go through to the next slide. I've mentioned risk assessments and the importance of risk assessments, and in my hospital we don't have those electronically yet. They're all done with sheets of paper. They're done with clinical judgment and proper consultation as well, and they're all risk assessed, and they are now, for the first time, there's a focus on revisiting those risks and documenting those risks as well. There's the standard MHRA example of an entrapment document you can use for risk assessment embedded in the learning, so you can download a version of that to make a start on your risk assessments. And the next slide is again taken from the e-learning. It highlights 9 different areas of risk, and these risks have been identified in patient safety incidents, and you've got to go through each and every one of these 9 items of risk, which reinforces those risks. And I'll just show you again what it looks like in the e-learning. So you have to move your cursor mouse to number 1. And number 1 will show you the area, and that talks about the equipment around the bed. Remember I said moving equipment. Number 2 talks about the rails, how people can get trapped and have been trapped within the rails. Number 3 is the bed base, and we talked about infills covering that one. Number 4 is the headboard, or the top of the board where the rail goes, both the grab rail and the bed rail. And number 5, of course, is the corresponding bottom. There's minimum distances required for number 5. Number 6 is the frame of the mattress, because of course people put the wrong mattresses on as well, and the bottom of the rail and the mattress as well. So there's all these gaps that appear in beds and bed rails, and the end rail as well. So there's an entrapment issue at the end rail where you put the bed rail. And number 9, of course, and this refers to the standards, is the minimum gap and distance between the rails themselves as well. Wow, if only we knew. He says, if only we knew. So that's reinforced in the e-learning. So embedded into the e-learning, we've got two little videos. One is a couple of minutes long. That's this one from my colleagues in Kirklees Council. And they produced this video on YouTube, and we've asked them permission, and they've given us permission. This is embedded within the e-learning, so it's only 2 minutes long, and I'll just show you. There's no audio apart from a bit of music. And again, it just goes to reinforce using the visual messages around the importance of risks around beds and grab handles. Okay, so that was the one of the videos that's embedded into the training course from our colleagues in Kirklees Council. We've got a second video, but I'm going to skip the video I'm conscious of time. But just to mention that the second video covers the measurement and standards related in the standards about the gaps that are required between the end of the bed frames, etc. And you can get hold of some very, very useful measure cards. Now, I've got these measure cards on my desk. I was very lucky to be able to get some funding this year and bought a whole stack of measure cards. I've got them here with me and we use them on the ward. And then really disappointingly, the hyperlink to this company NRS, which is the bed supplier, we had to delete last week because the company's gone into liquidation. So I don't think you can get measure cards from them anymore, but you might be able to buy them from another supplier. So you'll see they're double-sided, and lots of people now get these where there's a 120 millimeter measurement, there's a 60 millimeter measurement, a 220, and I don't know why it's 318. It would have been really good if the British standard made it 320 just to make the numbers rounded, but they are the measurements that you need to have. And the little easy to wipe laminated cards are something that really people ought to be considering having as well to reinforce those distance measurements. I think you saw from the video from Kirklees when someone put a mattress on top of a mattress, and the next thing you know, that minimum height distance was breached, and that is an absolute false hazard just waiting to happen. So the video again is embedded into the e-learning as well, and that video is about 6 minutes long. It just shows the lady there using all the measure cards. Okay then, so this is the summary information coming up that we know that entrapment is around the chest and the neck. It still is sort of classified as a never event. I believe never events are being reviewed as we speak at the moment. Perhaps my eminent colleagues online can give us an update on that one. But yeah, a never event means it shouldn't happen. There's enough information out there. There's enough training out there. It's a known issue and you really should sort these things out. We shouldn't be having people trapped in beds and bed frames. We can't believe it's still happening because the stuff is out there, but the training wasn't there, you see. The risk factors, of course, are all around poor maintenance and incompatible equipment. That still exists. People are still taking off bed rails or removing clamp bed rails and leaving them in rooms. And when you put one on, that can increase a falls risk as well. It isn't just adults and children. It's people with a typical anatomy, which means it's the shape and size of the human person, not whether they're adult, male, pediatric. It doesn't matter. It's what is the shape of the human? Can they fit in a bed? And you may actually cause more risk by putting the wrong sized patient in the wrong sized bed. And I've already mentioned about safety standards, and standards are there to hopefully guide the manufacturer to make sure the manufacturer are building and designing products to the best of their ability in line with all the safety standards. But no doubt you will, because beds can last for many, many years. You might have beds that are out there in clinical use that don't comply to any of these standards. It doesn't mean to say you have to scrap them, but you need to be aware that they don't, and they should be on some sort of maintenance, risk assessment, or replacement schedule going forward. Hopefully, your organization has got a policy or a procedure on replacing medical devices, including beds. Hopefully somebody in your organization is managing your bed contract, whether it's internal or external. And if it's an externally provided contract, someone's reviewing that as an independent person and making sure that you meet the deadlines that was in the alert. Now, I know a lot of people haven't yet, but you need to report back on that for CQC and HIW compliance. And of course, you need your tailored training. The e-learning course is not meant to replace learning. It's meant for the broad brushed approach to raise the awareness with every member of staff and employee. And then you have face-to-face training and product specific training that's followed on, usually by your manual handling or bed training organization. Really, really importantly around your inventory is to make sure you've got an inventory of what's in your organization, and that if you are paying for maintenance, that the maintenance gets done and you prioritize those that are in the worst condition. That's part of health and safety legislation anyway, and it should be done. And of course, I've reinforced this on at least 3 occasions. It's not just making sure you've got the risk assessments in place and you file them away and you never revisit them, because patient's condition changes. And as the measurement guide shows, if you move a bed into a different room, you might introduce a whole set of other hazards. So it's not just the clinical condition, it's if anything changes. We'd like to think that this e-learning course that we've developed does cover everything from risk and reporting and maintenance, and it gives guidance to everybody in line with what the alert asked us to do as well. It does align with the health and safety legislation, regulations, mental capacity and Health and Social Care Act requirements. We believe it ticks all those boxes. And if you don't comply to the alert, of course, then you'll have the CQC to answer for in England and HIW. And I think Scotland and Ireland have their own reportable mechanisms as well. You've got to engage with the families and patients and carers in bed rails. At the end of the day, you know, it's their loved one that's going to be sitting inside them. I got personal experience. My mum passed away recently, and she was in a bed at home. And the first thing I did when the bed arrived, I asked for the risk assessment. How cheeky was that? And then as she deteriorated, bless her, they actually changed the bed and they did everything. Not because they knew who I was, but they did everything because they had everything lined up anyway. So I was really pleased to see that. Okay, conclusion, 2 slides to go. It is a serious concern, beds and entrapment and risk. There are fatalities and serious injuries continuing to be reported because we are not using these products properly. And the MHRA in their alert, and it's a national alert, it isn't just from the MHRA, that's come from lots of organisations that contributed towards it, myself included in my organisation. It's about making sure that things improve, making sure that you have robust systems in place, and making sure there's a legal requirement about maintenance. My last slide then. We think that this free e-learning course is a critical step forward to helping to standardize some training and setting the bar at a certain point, increasing awareness. I learned loads putting this course together. As I've said, I didn't know about Doll's assessment. I didn't know about lateral turning devices. And I didn't even know that there was a falls prevention network, which I now know about as well. And it's also empowering staff to make those important decisions, life-changing and life-altering decisions that happen in the clinical workspace. But most importantly, we can reduce avoidable harm. And I think we can improve patient safety and just continue this support, this culture of safety that comes from the MHRA and our NHS patient safety colleagues. So I think if we do that, I think that it'll be a better place. So there we go. That's the end of my presentation. I'm going to stop sharing now, if that's okay. And I believe maybe open up to any questions, if anybody's got any questions. So I'll stop that, and hopefully I'm not sharing any more, Simon.
That's good. Thanks, Paul. That was brilliant. I don't know if Julie's still there.
She's here.
Oh, she's here. That's fine.
Sorry, she turned her camera off because the quality was going a bit, and I missed the. I was the cliffhanger about you with your bed rail with your mum in the bedroom. I just thought, but I'll catch up with you after Isabel.
It was very quick. What happened was my mum, she died of cancer recently. She was terminally ill, so she was sent home on a bed. And the first thing I asked was, where's the risk assessment, which they produced? And then as she got worse, and the team that came were all trained. They knew they changed the bed. They knew what we do, and they changed it all. Not just because they knew it was me, because they already had that embedded in their training program. I just sat back and watched them do a fantastic job. So they were amazing.
That's really good to hear, and thank you for sharing that personal story with us, Paul. And thank you hugely for a very informative presentation there. I mean, I don't know if we've broken the record for attendances.
Yeah,
we topped out.
Yeah, we topped out about 180, I think. So,
yeah,
wow.
Really, really well attended. So thank you everyone who's come on.
And thank you very much. We've had a couple of questions. I'll try and pick out a few. Unfortunately, we can't sort of unmute you, otherwise the whole thing will break the interweb, I think, if we try and do all that. So you'd have to trust me, I'm afraid. There was a comment here from Raoul in the Wirral, who it sounds as if his local organisation has put a blanket ban on ordering rails, which I thought was an interesting response. Because I think that, and Paul, you mentioned this, they're not right for everybody, but of course they are right for some in some circumstances, and it is about that individualised risk assessment. So I think that's an interesting response there in the Wirral, but I guess for good reason, perhaps. A person called Anonymous.
Anonymous.
Anonymous. Asking if patients on trolleys in areas such as theatres, emergency departments, endoscopy, etc., should patients be risk assessed using those equipment?
Yes, because trolleys are part of the alert. Absolutely, they're not excluded. I mean, perhaps I didn't focus on the message enough, but you can clearly see that this learning is about risk assessments for any patient on a bed, trolley, any device. Yeah, absolutely, yes.
Yeah, and certainly from my perspective, because we were feeding reported incidents to the MHRA, so I can certainly remember one where, sadly, it was a fatality where a patient had become entrapped in an ED trolley. And essentially, if you think about it, they're on these trolleys for such a long time now, it's essentially operating as a bed. So the same sort of risk assessment and same care assessment needs to come into place. And also, once upon a time, you used to have in recovery, one patient, one trolley, one staff, and repeat. That's not the case these days, as we well know. So you may well have staff caring for a number of patients. So we need to think about it in those terms. Similarly, when I was thinking about the reported devices, you mentioned about the lateral turning devices, and we've mentioned that a couple of times, Paul. And I can tell you about the incidents about that, and it's about the patient. By definition, they are very immobile, very often needing these devices that turn the patient to stop pressure ulcers forming, and so very often they can't right themselves if they go out of their, of a degree of turn, if you like, and we had incidents where the patients were face planting into bumpers and rails, and of course there's this asphyxiation risk there, so that's where that all came from. So these were incidents that this, you the audience had reported, and that's how these things then become actions. The other thing I was going to ask you about risk assessment, and again it's Anne Anonymous's friend, about whether cognitive impairment should be considered as a risk factor. I don't know if you want to expand upon that and maybe talk about the risk assessment itself and
yeah, absolutely. I mean, I didn't get a chance to go through all the modules. Quite short they are, but there is, when you come to the risk assessment, and of course it's different for children as well, the cognitive risk assessment is part of the risk assessment, and we focus in on the sorts of things you should be looking for. Cognition, people's level of understanding, etc. That's focused in with some suggestions as well as to what you might ought to consider in this instance. So it's quite an interactive course, and I said you should try it and see what you think and feedback and let us know. But I can see the questions in the Q&A, and yeah, there's at least one or two on cognitive state, and that is included. There's another one on there about and we came up against this, about revisiting the 16,000 risk assessments that we've got in community. And we wrote a risk assessment ourselves that said, we can't deal with the 16,000 risk assessments that are out there. We're just going to move forward with what we got now, and note for the alert that we've identified the fact that we've got risk assessments in place. Some of those patients may no longer be with us, Julie. We're not going to go out looking for patients over the last 10 years. And that was noted by the health board and realized that we then deal with patients as and when we can going forward. So it's the new process that we've got now. We can't possibly go back over 16,000 patients or 16,000 devices we had that had been sent out to our community, the vast majority of which would have ended up in a scrapyard by now or thrown out in a skip anyway. So that's how we address that.
Yeah, it's a really fascinating point, and I know the MHRA hummed and hawed, and we thought about this very, very significantly, because very often of the serious reports that we saw where the equipment had been in the home for an extended period, and there was evidence that it hadn't been maintained, or the patient's condition had changed, there was significant difference. And so when the thing was first prescribed, it was tickety-boo, but 6 years down the line, no longer. And that's where we were seeing a significant number of the harms, and we couldn't walk past that and not tell the system, but completely understanding that to go back and retrospectively assess thousands upon thousands of prescriptions. But I guess the thing there, why we left it in, was that in that intervening 6 years, just for argument's sake, there'll be somebody who'll be seeing that patient.
True, yeah.
And we would like to think that with learning like this, that's going to be so blanket, so widespread, that an individual who's coming into contact with that patient will take one look at the situation and think, oh, hang on, that's not the same, that can't be right, I know that's not right, let's do something about it. So that's why we've sort of gone at it from.
Do you know what? I heard the phrase, I've used it before. It's look, Paul, when you do stuff like this, don't try to eat the elephant. You are not going to just start small and grow it, and eventually it becomes organic then. And as you said, because the course is so easy to do and so easy to follow, and it reinforces all those key messages, you become almost an expert yourself. You walk into a room and go, that doesn't look right. I now know that's wrong. I honestly didn't realize that you couldn't put a mattress on top of a mattress. I thought, why not? Surely you can put a mattress on top, or an airbed mattress on top of a mattress. But I now realize, whoa, you're increasing the height of that bed. The patient's going to have a risk of falling. And if we all know this, I think we'll all raise the bar, won't we?
That's exactly that. And, you don't know what you don't know.
That's it, isn't it?
Yeah. You don't. So hopefully that's the answer to a couple of those questions about the reassessment aspects, and then maybe sort of think a bit more widely about, you can't keep people on your books forever and a day, but there might be other people who have routine and regular contact with that patient who can have a responsibility, but they need to be trained to know what they're looking for.
Sure. Yeah, absolutely. Yeah.
All right, Ruth from the MHRA. Hello, Ruth, you're on the call. That's great. Yeah, MHRA have reports of injuries and death on trolleys as well as beds. Yes, absolutely the case. Do split rails designed to aid egress with gap integrated in the design to safely exit eliminate the risk of a patient climbing over if up? Do split rails designed to safely exit? I'm guessing, are you thinking, it's difficult to second guess what you've written here, with a split side rail, are you thinking of the type, I wonder, where it drops, one half drops, or whether you're thinking the going to gap in the middle where it's a wider gap, so that person, it's almost acting like a bed lever. You know what the type, but actually the person can get out through the middle. I'm not sure. Will it eliminate the risk of a patient climbing over the top if up? Nothing will, in my clinical experience, will eliminate the risk of patient climbing over anything at all if they're so, minded to do. That would be my response to that. If there's any risk at all that you think the patient, for whatever set of reasons, is going to climb over anything, assume that they will, and think about what else you might want to do. So I don't know. Does that seem reasonable? That response, I'm not quite.
I think so. I can say the sort of question because there's all different types of designs, isn't it? But really importantly, the reinforced messages is bed rails are not there to trap and keep a patient in the bed. That's not what they're for, because they will climb over. If they're going to climb, they're going to climb, aren't they? That's not what they're going to do.
That's right. We've got somebody asked about the risk assessment. We could put that up on the future site, couldn't we? Because I mean, basically, I think you just nicked the old MPSA.
Yeah, well, we've got one as well. So
we've got one in Wales.
We've got a brand new one that we've used regionally within Wales, within Swansea area. That's actually been designed for our community issuing department, because all our beds are issued through a community services department, and they've designed it and they're using it and trialed it. So more than willing to share anything that we've got.
I think the best thing to do here, Simon, would be I'm sure we've got a section in the resources section on the network for bed rails or something like that. We'll put a folder in there, and then we'll get people to add in their assessments. I think that'd be the easiest thing. So we can use the national one. We can put your one in there, Paul, and anybody else who's part of the network can also upload into that folder as a resource for everybody to look at, to see how people are managing it locally with their risk assessments. And that, Claire, that might help with your question too about the specific risk assessment for trolleys.
Yeah, we're converting. So the one that's done by our community issuing joint equipment stores is designed on paper, but it's electronic. So it's going to be an electronic system that they're going to be using.
So that their Epic system then.
Yeah. Well, we use something different in our hospital. We use it's called the Welsh Nursing Record, WNR record, and they are actually going to be transferring the risk assessment over into the Welsh electronic record. So we're going electronic, but of course the advantage with an electronic record is you can get reminders built into the system then as well, can't you, about revisiting risk assessment. So it's not perfect, but we're on our journey, I think.
Thank you, Paul. That's helpful to background there. And Claire, I guess I don't know where you're calling from, however, but it's usually something that would need to be sorted out at trust level. So if there's a risk assessment you need to be using and it needs to be plugged into your Epic, there'll be somebody who's managing the Epic system, your information officer or somebody in your trust, who will be the person to contact with regard to uploading whatever assessment you want uploaded to the system, because there'll be a process for that, I imagine, which is what you're sort of referring to there, Paul, I'm guessing, how you're dealing with it in Welsh Wales. Okay. With the requirement for regular reviews and ongoing reviews, what is the view on who is responsible for that, given they may not be under an active caseload? Yeah, struggling to get locally to get consensus on who needs to take responsibility. I mean, we have sort of touched on that previously, but I think it is a conversation you need to have locally, because it depends on what services you've got, and each locality will be set up somewhat differently and have ongoing responsibility for patients. But I mean, there will be some patients who are lost to follow up, of course, and there'll be quite a lot, I imagine. So, they'll be off books, everybody's books. But I think that's the point that maybe Paul and I were making earlier, that there'll be somebody who will be coming into that household. And that might be a social care person, that might be a care assistant from a care provider. That could be a number of persons. But equally, if we upskill all of them, they should be able to eyeball when something's not looking right or maybe looking not safe, and able to escalate that to the correct people to go and do something about it.
Do you know, I got a bit of an anecdote, and it's a true story, this, Julie, and I've used it many times, where we had a patient many years ago that went home in Swansea, and it was end-of-life patient, and we had to do a risk assessment on the house before they could go home. Of course, there's a risk assessment on the gas and central heating system. We had to check that as well. We had to check the environment and the bed and access and egress and everything. So they went and did the risk assessment, and then they got the bed home. They got the relative home, and 2 days later, when the district nurses went in, they'd moved the bed. They'd moved the bed into the front room, and there was no room in the front room. You couldn't access the patient. It was a dangerous environment. So all the risk assessment had been completely undone by moving the patient into a different room. And when they asked the relatives, and this is a documented story, why have you moved your mum out of the bed, out of the front room into the back room? They said, because we got no room for the daughter's pony, and we had to put the pony in the front room. So in deepest Welsh Wales, and that is true story. Very rural. They put the house. They put the family horse in the front room, and they moved the mother to the back room. So they moved the environment and changed all the risk assessments. Messed it all up.
Yeah. Okay.
Messed it all up.
The joys of rural nursing.
Well, joys of nursing, isn't it?
Oh, definitely. Talking about rural, we've got a question here from our Scottish colleagues on the call. How can they access the e-learning module in Scotland? Are there links? I guess, did you say in the UK it's going to be on e-learning for health?
No, what it is, so it's on ESR for Wales, ESR for England, Scotland and Ireland if they use it, and also my colleagues in Wales who have hosted it on the non-NHS platform Learning at Wales. I think it was in one of the slides. They're going to make that freely available. You keep your own training records, you keep your own database who's done it, and we would just encourage anybody to use it and feedback in. I mean, the reports we've had back are really, really good at the moment, and it's just been shortlisted as well for an NHS Wales award for not for the content so much, because we think it's excellent, but for multi-collaboration and cross-boundary working, because we worked with OT departments and nurses and district communities, and we've all worked together to produce something that we think works across many, many boundaries.
Yeah, I would tend to agree. Well, and I wish you well with all the awards. I think it's well deserved. There's an interesting. I love this group because you're always so very good at thinking about things in a very different way, and this is the joy of why we like to do this sort of work. There's somebody here who's redesigning their risk assessment in a way that staff have to justify using the rails as opposed to justify not using them. Massive cultural change. I really like that idea. Yeah, so asking that question. So why do we need them? What is this adding to the situation?
If you look at the literature and look at all the research going back 20 years, it says, don't just, carte blanche start using them, because you can introduce more risk by just throwing in bed rails. Yeah. I really do like that question.
Yeah, I do too.
Yeah, good. Yeah,
thank you. And that's another anonymous.
That's Anne again, yeah.
That's Anne again. But no, what a lovely way to challenge our thinking, and also challenge the thinking and standing there in front of the patient, thinking, what is this adding to the situation here? What problem we're trying to solve, and is this the right solution? Donna's asking, would you encourage care homes to access this training? I think this answer is absolutely yes.
100%.
100%. Yeah, absolutely. And we saw plenty.
We will make it free. We will make it free. Whatever we'll do, we will make it free. If I have to change the access login to Learning at Wales, which is already there, to make it universally available for free. Absolutely.
Just a quick one. I'm very conscious of the time, but as ever is the case, you're all getting typing like mad now. Does one of the modules cover atypical anatomy? Yes, it does, doesn't it?
Yes.
Yeah. We were
covers
very
the
careful
details around that. Yeah.
And we were careful to explain that, and certainly we came up with the phrase atypical anatomy because we were seeing so many different reports where as you said, people were wider, longer, shorter, taller, missing limbs, so double amputees. You could argue that is actually a shorter person, in terms of the dimensions of the body. So, but that's covered off in the module nicely. So yeah, thank you. It is. where can we obtain the slides? I think we've already said, have we not, that we're going to get the slides out to you by the email system, but we'll also put them permanently on the Future NHS website in the resources section, so that they'll be there forever. And in fact, there's room there for people to post up their own local assessments as well, which is better than putting it in the chat on that site, to be honest, because it's difficult to go back and find things. It's easier to put it in the resource section, then it's there for posterity. So also pinch your great ideas. Okay. Oh, what is the actual name of the course? I missed the slide with it on. Do you remember?
If you go, it's on the front slide, but if you go to the, it's on one of the slides. If you go to the ESR software program, which hopefully all NHS staff should be able to do so, go to courses and put the word beds. That's all you've got to type is the word beds. I've actually got as well, I'll share it with you, Julie, a little Word document, which is a pictorial diagram of how to access the learning through ESR. And it shows you which boxes to tick on as well. So I'll share that with you. And as I said, I'm double checking as we speak. It's going to be linked to ESR for Scotland, England, Wales, Northern Ireland, and the Learning at Wales website. It's got the same title as well. And it covers, it's actually the title of the alert, I think is what it is.
Thank you. And is there a certificate they download? I think there is at the end. There is, isn't there? Yeah.
Each if you do it through ESR, it gives you a certificate at the end, and you get a screen grab as well.
Yeah.
If you don't use ESR, I can see someone using the electronic staff record, and they use something different, then we might be able to make that available. But if it's going to be available through the Learning at Wales, which is for the UK wide for free, then that will issue a certificate anyway.
Yeah. And the person who's asking there, because they use TURAS, I don't know what that system is, but I would go to whoever your learning lead is in your organisation and say, can we access this course, please? And can we get it on the competency framework for whoever it is you need it to be, and have that discussion with them. Simon, we are out of time. We could go on. Look at all these questions. No,
they're still flying in. So I think probably we will, I think they seem to have stopped now. I think we've probably covered the majority. So we will we'll call it there. And obviously, like you said, Julie, I think we'll get everything up on the, so if people, I think somebody asked where was it on the workspace. If you just go to resources and equipment, and then within there is a folder for bed rails and trolleys, so we will put it in there. Paul, a number of people have sent me email addresses to send information on, so am I okay just to sort of share that with you, and then you just get in touch with them directly? That's probably the easiest. So I think it just remains for me to say thank you very much to Paul Lee for a brilliant session today, and to Julie for chairing. Also, don't forget we have 2 more webinars next week on the hot topics that Julie had mentioned earlier. So we've got Shona McKinnon from Greater Glasgow and Clyde. We'll run a session on deconditioning on Monday, the 22nd of September at 12, the slightly earlier time of 12 p.m. And Carrie Tyler from Mid and South Essex will run a session on a new quality improvement initiative that she's leading called the Toilet Runway Project. And that will be on Friday, the 26th of September, again at 12 midday. So we hope you can all join us for those. Have a brilliant Falls Awareness Week, and keep us updated with all of your activities. Okay. Thank you very much, everyone.
Thank you.
Yeah, cheers, Simon. Thanks, everybody. Keep safe.
Bye
for now.
Bye.
Bye.